Welcome to this sponsor innovation webinar, The Role of a Host Response Test in Early Identification and Appropriate Intervention for Sepsis. Sepsis Alliance gratefully acknowledges the support provided for the Sepsis Alliance clinical community and for this webinar by Immunexpress. Sepsis Alliance develops sepsis awareness and education programs. Our mission is to save lives and reduce suffering by improving sepsis awareness and care, both for the public and for healthcare providers. Quick disclaimer, the information presented in this webinar is intended for educational purposes only. So with that, I'm so excited to introduce our presenter for this session, Dr. Roy Davis. Roy is the Chief Medical Officer at Immunexpress. He has 30 years experience in clinical medicine, including neonatal and pediatric critical care, and hospital administration as clinical assistant professor at the University of Washington, and as a consultant in healthcare standards and quality of care delivered. In the interest of time, I will let you read through the rest of Roy's bio. So Roy, thank you so much for being here, and I will turn it over to you.
Welcome. Today I'd like to talk to you about the role of a host response test in the early identification and appropriate therapeutic intervention in patients with suspected of sepsis. As an overview, we'd like to address the challenges of sepsis diagnosis and management, sepsis definitions, the use of sepsis bundles, the challenges in early identification and early appropriate therapy, and then the role of a host response test with regards to Sepsis Site Rapid in the clinical validation and of the test, transition to a near-patient molecular platform, and the performance of the test in the diagnosis of sepsis. We'll review briefly clinical workflow and sepsis program triage, the impact of Sepsis Site Rapid on that diagnostic uncertainty, and then finally, a possible role of Sepsis Site Rapid in COVID-19 patients. Sepsis diagnosis and management. One of the major challenges we face as a clinician is to identify that patient and recognize the patient who has sepsis without obvious organ dysfunction so that we can apply early and appropriate therapy to that patient before they deteriorate. The diagnosis of sepsis is driven by a number of factors. One is the level of suspicion, the history, physical exam, clinical findings, and today the SIRS and QSOFA criteria. This is variable depending on the practitioner's skill. There are multiple non-specific laboratory tests that we use, including blood cultures, which are drawn but unable to drive early management. Early imaging in an attempt to find and confirm the source of this infection. And then the pressure that we have today for early intervention to impact morbidity and mortality and outcomes overall. Sepsis definition was changed in 2016 to the sepsis 3 definitions. There are 2 definitions. One is a definition of sepsis as a life-threatening condition with dysregulated host response to infection, and then the definition for septic shock. Sepsis 3 recommended using SOFA or QSOFA to define sepsis. The SOFA score is a burdensome information to collect. It's not usually available at the bedside at the time, especially in the emergency room. It's to impact clinical decision-making. QSOFA is easy to collect, but has its limitations based on the fact that it relies upon the clinician to recognize infection as the cause of organ failure, and pre-existing chronic disease processes or comorbidities may impact that score. There continues to be much discussion with regards to the role of SIRS versus QSOFA and the impact of these criteria on the ability to early recognize patients with possible sepsis. Several studies suggest SIRS criteria continue to be used for suspicion of sepsis, and that QSOFA could be used as a triaging tool to assign a location of care and process and risk of severity. Driven by the recognition that sepsis is a medical emergency, multiple hospitals now have developed triage algorithms and bundles of care to identify possible sepsis in patients both in the emergency room and on the floors, and initiate early goal-directed treatment and therapy processes. This has led to the development of manual or electronic early warning systems such as MUSE, SUSE, we've all heard these anagrams, and the use of code sepsis and rapid response teams to initiate early evaluation of these patients who are at risk for a medical emergency process. This has led to some problems with regards to alert fatigue and or overuse in some hospitals, limiting their advantage in some places. Driven by these early warning systems and rapid triage processes, sepsis bundles have been developed that include clinical criteria for suspicion of sepsis and diagnostic and treatment algorithms. Within these sepsis bundles, order sets for diagnostic laboratory tests, radiological studies, and treatment processes have been implemented to move this process forward to address early recognition and process control. Sepsis order sets or bundles, there are two models generally used in most hospitals today. One is an inclusive model that's usually developed by a multidisciplinary team who are interested in and experts in sepsis, reviewed by the medical staff, nursing, and pharmacy, and this develops a sepsis initial evaluation laboratory test bundle that includes things such as CBC, diff platelets, lactate, etc. And this limits the overuse of multiple tests early in the process that may not have value for the diagnosis. The other model is the individual model, where the physician can order these tests individually as seen fit by that person. This sometimes results in multiple tests being ordered early and what we call the absence of diagnostic stewards. So our decisions with regards to the diagnosis of sepsis still rely on multiple clinical variables that suffer from the disadvantages that they have low sensitivity and low specificity. For example, we use blood cultures as one of our confirmatory processes that take time. They are difficult to have contamination associated with them, and this increases hospital stay, difficulty in diagnosis, and length of stay is impacted. And as you all know, false positive and false negative blood cultures lead to the fact that approximately 46% of charges are increased because of that, and 25% increase in length of stay is impacted by the false positive blood culture results that we sometimes get. These broad non-specific biomarkers that we use, such as CRP and PCT, which are helpful but not specific for sepsis. Current challenges don't address such things as discriminating SIRS from sepsis. The diagnostic uncertainty remains high, and that clinical diagnosis on admission to the ICU corresponds poorly with the true presence of infection. For example, a number of studies have shown that 43% of patients treated for sepsis ultimately end up not having sepsis on the ICU. Slow turnaround times impact our confirmatory culture process and our ability to confirm the diagnosis early, overuse of antibiotics resulting in that process. This leads to higher costs, and if they are driven by the new sepsis definitions and CMS requirements, we need to implement appropriate antibiotic stewardship and therapy within 1 to 3 hours. Higher costs and mortality associated with this delayed diagnosis is a major problem within our diagnosis process. So how can, and what is Septicide host response technology? Septicide measures mRNA and white blood cells that are generating an expression from multiple genes within the white cells. The host response is specific to infection based on systemic inflammation. It is independent of the pathogen causing the sepsis, and it's not reliant on finding the pathogen within the blood sample. The test runs in about 60 minutes with a turnaround time and translates to a clinical risk score that's 0 to 15. This score reports the likelihood of sepsis. It's independent of severity, and it gives actionable results in approximately 100% of the time based on clinical information that's associated with it. Septicide has been validated and reported on in independent peer-reviewed publications. Initially, we have 4 pragmatic clinical studies, including the initial validation study by Miller et al. There are a number of explanatory in silico studies that have been performed, and now there are 6 articles reviewing the role of Septicide Rapid in the diagnosis of sepsis in different locations and areas. Septicide Lab is the initial clinical validation test that was used to make this diagnosis and this host response test available. The study was on adult ICU admissions. There were 8 sites within this study, 7 in the United States and 1 in the Netherlands. The criteria for admission to the study were 2 or more SIRS criteria and the initiation of therapeutic antibiotics at the time of admission. Each patient had blood drawn for a Septicide Lab test, and this generated a septic score with bands 1 through 4, with increasing probability of sepsis. The confirmatory sepsis process was done using a 3-physician panel, a retrospective patient classification, and they had a unanimous group, a consensus group, and in those groups that are indeterminate where all disagreed, they were forced to make a decision. The graph on the right here shows the area under the curve from a ROC AUC standpoint of each unanimous, consensus, and forced decision process, showing good correlation between the diagnosis of sepsis versus SIRS, with a ROC AUC of 0.89 to 0.82, depending on whether the diagnosis was unanimous or forced. Septicite Rapid is a second-generation predicate that was based on the predicate 510 clay-cleared Septicite lab test. The Septicite lab test was a manual test, bench test, with multiple hands-on processes, and had a turnaround time of about 6 hours. Understanding that this obviously was not going to impact early diagnosis, we have developed a platform-based process that is near-to-patient care process that uses the IDILA platform. It's fully automated, cartridge-based, and has a turnaround time of approximately 1 hour. Septicite Rapid uses a self-contained molecular in vitro diagnostic test that's specific for the BioCartis IDILA system. It's performed on a single-use, disposable, multi-chambered fluidic cartridge. This cartridge steps are all completely automated and integrated. It uses RT-PCR technology and results in a sepsis score. The higher sepsis score value being associated with a higher likelihood of infection-positive systemic inflammation, or sepsis, as opposed to infection-negative systemic inflammation, or SIRS. Septicite Rapid has undergone a correlation with 510 predicate Septicite Lab using 100 clinical samples that were tested on both Septicite Lab and Septicite Rapid. This graph demonstrates a good correlation for all values, all ranges, with a correlation coefficient of 0.94. These are all clinical samples drawn specifically to do this correlation. Septicite Rapid's ability to differentiate sepsis versus SIRS is clearly shown in these two diagrams. On the left here is a ROC AUC curve comparing the diagnosis of sepsis versus SIRS with an area under the curve correlation of 0.9. Next to that is a box whisker plot that shows clear differentiation between SIRS versus sepsis using Septicite Rapid. 195 samples were evaluated with 106 cases of sepsis and 89 cases of SIRS. On the right here is a graph that shows a logistic regression process using, in this group, usual CBC, diff, lactate, CRP, etc., which gives us a correlation from the standpoint of differentiating sepsis from SIRS of 0.73. When one adds PCT to this, remembering PCT is a test for bacterial infection, not for sepsis, as it does not differentiate between local or systemic, one can see that you raise your area under the curve to 0.85. Adding Septicite Rapid to this process increases the AUC from 0.73 to 0.95. So good differentiation with good correlation between the two. Septicite Rapid is reported as a score, and under that score are 3 bands. There are 3 bands associated with this process with a SIRS sepsis differentiation. Band 1 is a low risk of sepsis band. This group was evaluated using both the forced diagnosis and the unanimous diagnosis and resulted in a sensitivity of 95% and a negative predictive value of 91%. So this group has a low risk of having sepsis. The upper band, band 3, is a group of patients that have a high risk of sepsis. Using the same cohorts, showed a specificity of 86% and a positive predictive value of 80%. There is a small indeterminate band between bands 1 and 3 called band 2, in which the score is lower than the band 3 definition, and one you would use your regular laboratory and the score to make a decision whether to treat or further investigate this patient as probably not having sepsis. From the standpoint of how we see a host response being included in our present sepsis workflow, as you know, most places now have a sepsis triaging process that is either an ED using code sepsis or a sepsis early warning system on the floors, or general group roundings with regards to the RN intensivist, alerting them that the risk of sepsis is present. Based on that risk for sepsis, one would initiate a sepsis bundle order set to initially evaluate the patient and initiate therapy. This results usually in two groups of patients. Those patients who have a low risk of sepsis based on the initial lab tests are either started on antibiotics or tested further to decide whether they should be treated or further workup is necessary. And the second group is those patients who have abnormal initial lab tests suggesting sepsis, who are usually admitted, started on antibiotics early, and monitored, awaiting culture results and pathogen identification and antibiotic sensitivity testing. We see the fact that initiation and addition of Sepsis Site Rapid to that initial sepsis bundle adds a confirmatory process and impacts the initiation of antibiotics and the appropriate diagnosis. For example, in the group that had a low initial lab test suggesting low risk of sepsis, if this Sepsis Site Rapid test comes back with band 1, that would confirm that initial decision and perhaps initiate further workup for etiology of symptoms and perhaps discontinue antibiotics. But should that patient come back with a band 2 or 3, that would suggest that this patient has an increased probability of sepsis, and one would either initiate or continue antibiotics, work up the patient further for this imaging, etc., to evaluate for possible source. The use of Sepsis Site Rapid on the critically ill patients, if that result comes back as band 1, it would alert one to consider the possibility that this is infection-negative systemic inflammation, and one needs to work up the patient for clinical presentation lab imaging to determine a non-infectious cause of possible clinical symptoms. Regards to a band 2 or 3 presentation in these patients, this adds increased probability of sepsis, confirming one's initial suspicion and allowing one to continue a present therapeutic intervention. Recently, Prescott published an article on antibiotic use in the face of clinical suspicion of sepsis and probability of sepsis. And using that heat map, we have suggested that those patients falling in the lower left-hand corner have intensive search for diagnosis before initiating sepsis therapy. Presently, those patients that fall in this group have a higher risk of clinical suspicion of sepsis and initiated therapy early and continued on that therapy. Patients that fall in the intermediate group are usually started on antibiotics early in an attempt to meet CMS guidelines and initiate early therapy. This group of patients who have a low clinical suspicion but high probability are sometimes missed because of that low clinical suspicion. And we all initiate therapy in this group, early therapy, because of that high probability and high clinical suspicion. The addition of sepsis score and the banding process using Sepsis Site Rapid for this process can help confirm or change one's approach. For example, a group that falls in the lower left corner or the upper right corner, we would initiate therapy or monitor and evaluate appropriately without the score, but band 1 and band 3 would confirm one's initial impression. It's this group in the upper left-hand corner where we usually initiate therapy early because of clinical suspicion, but probability may be low. The fact that they come back with a band 1 would drive one to work this patient up further for a non-infectious cause of systemic inflammation if they come back with a band 3, confirming one's initial process of adding antibiotics. Those in the intermediate group, if they come back with a band 2, would increase your probability of sepsis and support your initiation of antibiotics. If band 1, further investigation. And then this group that has low clinical suspicion is a group that's frequently delayed in their initiation of therapy. The sepsis score comes back with a band 3. This would drive one to initiate therapy early. One of the questions we get frequently is the role of a host response test in patients who have malignancy or treated with immunosuppressants. This study looked at about 404 patients who had those clinical findings and or use of immunosuppressants, and were from patients clinically studied at the Academic Medical Center in Utrecht and Seattle Children's Hospital. The study used diagnostic performance using an ROC AUC curve. This figure breaks the groups up into the two cohorts of sepsis versus SIRS, and in this group shows those patients that were treated or not treated with corticosteroids. This compares normal sepsis versus SIRS untreated. Here we have a group of patients that were treated who had sepsis, who were treated with corticosteroids. versus a group of patients with SIRS who were on corticosteroids. Clearly differentiating sepsis and SIRS does not seem to impact the testing process from a host response standpoint. On this side, we have those patients treated with anti-neoplastic drugs compared to the normal SIRS versus sepsis differentiation with those patients with sepsis on anti-neoplastics, and the few patients we could find treated with anti-neoplastics who just had SIRS. Good differentiation. Numbers are somewhat low from a standpoint of being able to clearly say that differentiation. We show this group who had metastatic malignancies, similar differentiation of those patients with sepsis with metastatic malignancy and those patients with SIRS with metastatic malignancy. And finally, the group that had hematologic malignancy with sepsis, good scores, differentiating them from the few patients who had SIRS with hematologic malignancy. So I think there's good indication that Sepsis Rapid as a host response test is not impacted by the treatment with these immunosuppressants and/or malignancy presence. This clinical utility of using Sepsis Rapid within one's clinical process. From a sepsis diagnostic standpoint, it provides a rapid, accurate, and early sepsis diagnostic capability. It facilitates early appropriate treatment. It decreases delayed diagnosis of those patients who are not septic but are being evaluated for sepsis, i.e. infection-negative systemic inflammation. Not impacted by antibiotics early in the administration process, and improves compliance with those sepsis bundles that we all have to meet, which do impact the mortality and appropriate treatment process. It also increases appropriate early evaluation of patients who do not have a sepsis. From a diagnostic stewardship standpoint, Sepsis Rapid being included in the initial order set impacts the fact that with a directed order set, one can decrease the number of probably unnecessary initial tests ordered, and it directs appropriate early testing for those patients who do not have sepsis so that we don't delay that diagnostic process and order the appropriate test at the appropriate time. From an antibiotic stewardship standpoint, it allows one to initiate early appropriate antibiotics in those patients who are suspected of high probability of sepsis. And then in those patients who have infection-negative systemic inflammation, one can consider early cessation of antibiotics, resulting in a decreased long-term use of antibiotics in inappropriate cases. Recently, Immunexpress has received a BARDA contract to support clinical validation of Sepsis Rapid for triage of COVID-19 patients. This is to look for patients who present with SARS-CoV-2 positive testing who may have, at the time of admission, developed a sepsis related to the viral disease process. We have started to evaluate this process. Presently have two studies going on in the United States, but this is for some preliminary Sepsis Rapid performance in some clinical samples of patients who are at this stage are divided on the basis of their severity of disease presentation. Those with SARS-CoV-2 positive who were mild, those who had intermediate disease, severe disease not on the ICU, and then those patients who presented with SARS-CoV-2 who were positive and were on the ICU. One can see that one clearly differentiates this group as one moves up, and these patients with high scores may have suspicion of clinical sepsis due to SARS-CoV-2 positive. This is preliminary data, and we're presently doing a clinical prospective study to evaluate that. I want to thank you for your attention and would be very happy to address any questions that may come up.
Okay, great. Thanks so much, Roy. Let's go ahead and tackle some of these questions. If there are any that we don't get to, folks, because of time, we'll get you some answers via email. So our first question, Roy, is the positive predictive value of 80% with or without augmented data?
The positive predictive value is based entirely on the use of the Sepsis Rapid testing process. Augmented data obviously will improve that with regards to the use of your usual laboratory studies such as CBC, DIF, etc.
Excellent. Next question, are there any issues with false positives?
From the standpoint of false positives, this is a probability. And so there are issues with regards to, there is no gold standard with regards to the diagnosis of sepsis. So one questions our ability to make that comparison of false positives versus false negatives. What I can say is that from a negative standpoint, the negative predictive value is high. We had no positive blood cultures in that group throughout the studies that validated this process. So I think the important process is false negatives. Right now we overtreat, in fact, and if we don't want to miss that one positive patient that may be in the low risk of sepsis group, and that's why we use that negative predictive value of 90%.
Great, thank you. Next question, just a clarifier. Did you say that this is measuring bandwidth on the monocyte or just the bands on the white blood count? I think I missed that part.
So from the standpoint of the test measures the gene expression in white blood cells, primarily neutrophils, but it measures that gene expression and the mRNA that gene expresses. So it's not specific for any kind of white cell, and it's not specific to the white count itself. In fact, we can study white counts down to, we need around 250 white cells per microliter to run the test.
Got it. Okay. A couple more questions here and then we'll close up. Next question. Do you use built-in sepsis SIRS alerts to determine who should receive a septicite rapid test? If not, what parameters or alerts guides its use?
I think the guidance for the use is the suspicion of sepsis in those patients who have at least 2 SIRS criteria. That's the early detection of sepsis. We don't want to miss that early detection and await organ failure. A number of hospitals that I worked with have early warning systems such as a code sepsis process or a electronics process based on their EPIC electronic medical record that generates an early warning system. There's a problem with early warning systems with regards to the over suspicion and increased alarm alert. But those patients should have, if they initiate sepsis protocol, one should then add septicite rapid to that protocol for early diagnostic process.
Great, thank you. There's a question on any studies to show the difference in patient outcomes. I think we'll get you an answer to that question via email. Next question here. Does the test perform better with bacterial versus viral or fungal sepsis? For example, better positive and negative predictive value of bacterial, or is it the same across the board?
It appears to be the same across the board. From the viral to bacterial standpoint, obviously the definition of viral sepsis we struggle with, and also the confirmation that viral sepsis is present. And that's one of the reasons we're using SARS-CoV-2 positive patients, is to look at that, because at least we know they have a viral infection, that it's active, and they have clinical signs. We can look at organ dysfunction, etc., to confirm that diagnosis. But septicite rapid appears to pick up both viral, bacterial, and fungal infections inequality. We've just completed a evaluation of Candida, and it does that very well as well.
Got it. Okay. One other question here. Do you see a role for continued use of septicite to assess treatment response?
We think there might be a role in that. We have not studied that yet. We think there are 2 roles. One is to look at does the host response decrease rapidly over the 2 days post initiation of antibiotics, and can one stop treatment based on that? We haven't looked at that. And then the other is the possible role of evaluating patients day 5, day 10, day 15 who suddenly have symptoms on the ICU of possible infection, hospital-acquired infection. We see a great role for that, and we have some suggestion that that works very well based on the surgical study that Verboom did in the Netherlands.
Got it. Okay. There is a question about FDA clearance. I think we'll get you a response to that one via email as well. So at this point in time, Roy, I will let you go and we will close up the webinar. Thank you so much for your presentation and for answering those questions. We appreciate your time.
Thanks very much for having us.